Hello everyone, my name is Rahma and welcome back to my channel. For today's video we are going to talk about the high yield points from Psych. So these are some of the buzzwords or factoids or high yield things you want to be aware of that might come up to you in board questions or just some of the things I might ask, and again, like certain things that can be tricky. So just to kind of compile the most important things for you in Psych, this is going to be a video on the high yield points from that. So let's just begin. We have, again, this is mainly going to be targeted towards people who have already read at least a chapter in first aid, for example, or have cycled through Psych, for example. So this is obviously not going to be organized in any particular way. I'm just going to be throwing facts at you that you might need to know, or might make the difference for you when it comes to answering certain questions. So I'm not going to be explaining too much what they are. So without further ado, let's get started. We have something called presenilin 1 mutation. If you see the word presenilin 1 mutation, that is associated with early onset Alzheimer's, whereas ApoE4 allele mutation is late onset Alzheimer's. You're going to get lots of questions about schizophreniform or schizophrenia. So they are very similar, and a lot of these psychiatric disorders are dependent on a timeline of how long these symptoms have lasted. So if you looks like schizophrenia and it's lasting more than 6 months, then it's schizophrenia. But if it's less than 6 months, then go with schizophreniform as your answer. We have things called transference and countertransference. Transference is when the patient projects their feelings onto you as the physician, versus countertransference, where you as the physician are transferring your feelings onto the patient. So a simple example can be something like if a woman is going through a divorce and you are a male psychiatrist and you are speaking together and you ask her a question indirectly and she catches on this and then she snaps at you and she yells at you and she probably says something like, I don't like men who are indirect with their talk, so speak plainly or speak clearly to me. So she's transferring maybe her issues with her ex-husband onto you. Now, countertransference can also occur between the physician and the patient. So that can look something like where you maybe reflect and see a patient, perhaps you're an older doctor and you start to think of your patient perhaps as your son and you're having troubles, at home or something. So you project certain feelings about your patient who is similar age to your son onto them, and that would be patient to physician to patient. Again, that's countertransference. Transference is patient to physician. Next, if you are stuck and you have a case of bipolar disorder, the best treatment for it is going to be lithium. It is a mood stabilizer, but because we always memorize BPD and lithium together, you might get a trick question where they wheedle in a little bit of what the patient's creatinine is and some of their metabolites, and it looks like they have chronic kidney disease. So please avoid lithium as your choice for BPD. You want to go with valproate as your second option if the patient has chronic kidney disease. Next, again, beware in bipolar disease. So remember that bipolar disorder, with bipolar disorder, again, you have two polarities. You have, a hyper or a mania stage, and then you have depression. So if the patient comes to you, now chances are they're not going to come to you if they're having the mania stage. If they are in the depressive stage, they might come up to you as a psychiatrist and seek help. Now, if they come to you in the depressive stage and you're not screening for symptoms of mania, you might diagnose them with depression. And the problem with this is that it is believed that if you treat them for the depression, then you're going to leave the mania unchecked, and then they're going to go into a switch in mood polarity. So you want to be aware of that. So if you have symptoms of mania, will be triggered by if you do treat the depression first, and it's especially seen with a TCA called venlafaxine. Again, I'm not the best at pronouncing any of these things. If you want to quit smoking, the drug that of choice that you want to go with is bupropion, and you want to be aware of tachycardia and arrhythmias as side effects for it. It is often given with SSRIs to minimize another side effect for it, which is decreased sex drive. Another word for that is libido. Next, you have amitriptyline, which is another drug that can cause QT prolongation. You have something called mirtazapine, and mirtazapine, you want to think of a patient who has depression, and they also have anorexia nervosa. If you get this as your clinical vignette, go with mirtazapine as your best answer because it causes weight gain. So we're going to be kind of, killing two birds with one stone here, treating the depression and treating the anorexia, because you're going to be using mirtazapine for the depression and the side effect of weight gain to treat the anorexia nervosa. Now you have a condition called dissociative identity disorder. How can I know in my clinical vignette if I'm dealing with a case of DID? You want to look for two distinct personalities, plus memory gaps, plus symptoms, and the symptoms have to be totally unrelated to any drug use and medical illness. You really want to exclude the use of drugs or medical illness if you want to make a diagnosis of DID. You want to look for derealization plus auditory hallucinations plus history of abuse and neglect. Next is conduct disorder. This is kind of like the TV character, or what people obsessed with or call a psychopath. We call that conduct disorder. Again, with the psychiatry topics, you want to be aware that the name kind of changes depending on how old. So we call it conduct disorder if it is less than 18 years of age. And how do I know I'm dealing with this kind of personality type? You want to look for a patient who is constantly getting in trouble with the law. They are doing a lot of illegal things. They are burning things, they are damaging property, they are hurting animals. And when they progress into adulthood, so again, we have 18 years of age, if I'm getting these symptoms, it's called conduct disorder. After 18, we call it antisocial personality disorder. Now we want to differentiate between something called malingering and factitious disorder. What is the difference? A lot of people tend to confuse this. Malingering has a secondary gain. So both of them are going to be going to the doctor. Each of them have a different gain. So malingering is easier to start with, so you can understand it, because sometimes maybe we all do this. We go to the doctor, we're not really sick, right? But we are going there because we want a doctor's note so we can get off of work, right? So the gain is secondary. They want to get a doctor's note so they can get off of work. They are not really sick. Because they are not really sick, they are aware perhaps that they are lying, and they don't want to cooperate with the medical examination with you because they know that they're lying and they don't want you to catch them, right? So we call that malingering. And the key picture in the clinical vignette will be a patient who is not cooperative with the medical exam. Again, they don't want to catch you, they don't want to be caught faking their symptoms. On the other hand, factitious disorder is a mental disorder, and the goal is mostly internal or primary. They want empathy, they want care, they want attention. So they will go to many doctors in many different cities. You'll see that in perhaps their hospital records, and they are very cooperative with the medical exam. They want you to book them in the hospital. They want to do invasive procedures. They want to undergo surgeries. They will make up these symptoms, and you will go through with it because you want to care for them, and then perhaps you may be dealing with factitious disorder. Again, they are cooperative with the medical examination. Gender dysphoria is distress caused by mismatch between the expressed gender and the assigned gender for more than 6 months. This is different from a word called transvestic disorder. Transvestic is cross-dressing or fetishistic behavior. So the difference between them is that with cross-dressing or a transvestic disorder, typically there isn't a real distress happening with a transvestite. You're going to have a man who is dressing as a woman and he's getting sexual gratification from that, but his personality is maintained as male. That is transvestic disorder. Gender dysphoria, again, they have immense distress because they believe that the expressed gender or the assigned gender, there is a mismatch between that. So again, transvestic disorder, fetishistic disorder, the main goal is sexual gratification or desire. Like we've said, a transvestic is a male dresses as a woman because it is sexually exciting for him, but he still maintains the character or the attitude of a male. Fetishistic disorder, by definition, is an unusual attraction to certain non-sexual parts of the body or things. It can be things like feet or an inanimate object that is causing a social debilitation. This person cannot go outside, they cannot function in society because of this fetishistic disorder. Next is schizoid personality type. So this is different than schizophrenia or depression or anything like that. Schizoid you really want to be aware of because you will get lots of questions on this. This is someone who wants to be alone. They like to read. They look more introverted. They like to spend their time alone, but they are not depressed, right? Depression is someone who isolates, right? But it's debilitating. They cannot function in society. Whereas schizoid wants to be alone, but they still are a functional person within their own bubble, within their own realm, right? So we get a clinical picture of a father who brings his 16-year-old daughter in to see you, and he's telling you, you know, she doesn't take calls from people, she doesn't hang out with people that much, she spends her day in her room and all she does is read and listen to music, and you talk to her and you ask her about it and she just tells you, no, I'm fine, I'm totally okay with that, I just want to be left alone, then that it's more likely to be schizoid personality. Avoidant is something you want to be aware of as well. Avoidant is someone who wants relationships, but they have extreme low levels of self-esteem. They feel inadequate. They fear being rejected. So they want a relationship, but they can't. So you might get asked a question in one of your selections, maybe schizoid or avoidant or schizophrenic or depressed. Avoidant is the person who wants a relationship but can't. They fear that they will be rejected. They think that they're ugly. They think they are not worthy. That is going to be your avoidant personality. Anorexia nervosa, don't forget that they are at increased risk of fractures due to osteoporosis. This is because they have decreased vitamin D intake, decreased estrogen, and no menses. Hypophosphatemia, decreased sodium, decreased chloride, hypokalemia, everything is down with anorexia nervosa. Prolonged QT interval and something called sick euthyroid syndrome. You'll see that with anorexia. Autism and Rett syndrome. So you want to be aware of these two because they look similar, but there are key buzzwords that might help you. And again, do not depend on autism being purely for boys. Rett is always female, but sometimes you might always clump autism with boy. That's not always the case. They will perhaps maybe a trick question and you'll get a female with autism. So what do they look like? An autism spectrum, you have impaired social interactions and repetitive activity. With Rett syndrome, female only, and the progress is turned back. So the clinical vignette is actually going to be very clear. You're going to get parents that come into your office and they're going to complain to you about their baby girl, and she's progressed in her milestones. Remember, we have our pediatric milestones, and all of a sudden the mother notices she's going back, right? When you have that regression or regression for Rett's. And you're going to have hand movements, so it kind of looks like autism, because on autism you also have characteristic hand movements, so they look similar. Rett, female, autism, perhaps you want to memorize it as boy, but you might get a trick question with female that has autism as well. Agoraphobia is fear of public space or a situation where they can't seek help. Body dysmorphic disorder is a persistent preoccupation with a non-existent flaw in one's appearance. Most of us probably are aware of this. There's many celebrities that are celebrated for having body dysmorphic disorder, so most of us are familiar with this topic. Major depressive disorder and persistent depressive disorder. Again, it's a timeline thing. If it's lasting more than 2 weeks, it's major depressive. If it's more than 2 years, it's persistent depressive. Inhalants are recreational drugs common among adolescents. What are they? What are some examples? Aerosol, shoe polish, spray paint, glue. With the glue, you might get a rash on the lips and nose as a clue in your clinical vignette. How do we differentiate displacement and projection? Displacement is redirection of emotions from a real target to a neutral one, right? Your boss yells at you, and then you go home and you yell at your wife, right? So you want to yell back at your boss, but you can't. So you're going to go take it out on a neutral person who's your wife at home who hasn't done anything. So that is displacement. Projection is attributing your thoughts to another person, right? Or something that you've done wrong, or something that you are ashamed of, or your ego just doesn't want to deal with it, and you're going to project it to someone else, right? A man cheats on his wife, suddenly goes and accuses her of having an affair. That's projection. Okay, it's something that he has and he projects it onto other people and says, oh, you're the one who did that. That's projection. Displacement is taking, feelings, inappropriate feelings, you want to take it out on somebody, but you can't, so you displace it to somebody else. So again, it deals with power struggles, that's displacement. We already talked about transference and countertransference. Again, let's just repeat that. Transference is projecting from patient to physician. Countertransference is from physician to the patient. In normal grief, this is an important question. In normal grief, can you see hallucinations of the person who just passed? The answer is yes. Hallucinations and features of depression are a normal part of the grieving process. It is not considered pathological. So if a 5-year-old is brought to your office and the parents are telling you he's still talking to his grandma who just passed away, that's normal. If you get a clinical vignette of someone who is violent, extremely violent, plus hallucinations, plus a history of having smoked something, right? Plus muscle rigidity, pain intolerance. Okay, they are extremely strong. They're not feeling any pain. People, trying to stop them from this violent behavior. You want to think of PCP intoxication. Conjunctival injection plus impaired reaction time plus delusional thinking and hallucination. Think cannabis intoxication. Pica is the eating of non-nutritional foods. It is seen in iron deficiency. You're going to see things like spooning of the nails. Lanugo hair is seen in anorexic people. Parotitis is such a buzzword for bulimia. So you're going to have somebody who is inducing vomiting. You have certain signs. You're going to have, because they're vomiting, the enamel is going to be eroded, right? And how do they induce the vomiting? They stick their fingers into their throats, and that vomit, when they hit their gag reflex, they're going to injure here. So you're going to get calluses on the back of their hand. We call that Russell sign. And then that vomit is going to irritate the parotid glands. They're going to be enlarged. So you're going to get parotitis. Hypertensive crisis after eating cheese or cured meats or wine. So you have a cheese effect. Tyramine production increases norepinephrine and increases blood pressure if the patient is taking MAOIs. Delirium is reported in 50% of elderly after hip fracture surgery. Again, I don't know why, but this is maybe a question that you might see where delirium, again, is reported in 50% of elderly after hip fracture surgery. Bulimia is somebody who's constantly worried about their appearance and they do something about it. So they're going to purge, right? They're worried about their appearance, they want to do something, they're going to vomit, or they're going to take laxatives. Binge eating disorder is aware of their issue, but they don't do anything about it. They're going to consume large amounts of foods all of a sudden. And they're going to feel extremely guilty, but they're not going to take that extra step where a bulimic would induce vomiting or take laxatives. Frequent vomiting in bulimia is going to cause metabolic alkalosis. Makes sense. My vomit is acidic. I'm getting rid of my hydrogen. I'm going to have alkalosis. Metabolic alkalosis and hypokalemia and decreased urine chloride. Antipsychotics decrease dopamine. Dopamine inhibits prolactin. Remember, dopamine inhibits prolactin normally, so if I'm going to decrease it, you're going to get an increase in prolactin, and that's going to cause gynecomastia, which is a common side effect with some antipsychotics, as well as sexual dysfunction, and will trigger Parkinsonian symptoms. You want to treat it by a dose reduction or pick centrally acting agents to avoid the peripheral effects. Oppositional defiant disorder. This is somebody who does not like to listen to any authority. Now, you want to really be careful with this one because typically you might have some what looks like oppositional defiant disorder in a child who doesn't want to listen to their parents. But you want to, be able to diagnose it or observe it in multiple different settings. So it's not just at home or with their sibling. That's not oppositional defiant disorder. This is in all aspects of social interactions. They are opposed to any authority. So it's directed towards authority, a teacher, a parent for more than 6 months, and it impairs their social functioning. How do we improve adherence to medication? You want to schedule more follow-up, more appointments with your patient, which will improve the trust and rapport in the patient and the patient-doctor relationship. In borderline personality, okay? Borderline personality, the defense that they use is splitting. They do not see the world as gray areas. You're either black or white. You're either good or bad. That is the defense that they use. People who have borderline personality disorder. For example, all doctors are really great, all nurses are terrible. That's one example. They also have severe abandonment issues, unstable relationship. They do have suicidal threats, so if you get somebody coming in and complaining, saying, I'm scared of breaking up with my girlfriend because she keeps threatening that she's going to kill herself if I leave her, that might be a clue to a borderline personality. And typically it's more common in women. Example, again, threatens to kill herself if her boyfriend leaves her. Treat an overdose of TCA with sodium bicarbonate. Atropine for OPP poisoning, naloxone for opioid poisoning, cyproheptadine for serotonin syndrome, dantrolene for neuroleptic malignant syndrome, and for malignant hyperthermia. Don't forget, dantrolene for neuroleptic malignant syndrome. In stages of change, right, how do we change our habits or our problems? Contemplation is when the patient is aware of a problem, but they are not ready to fix it, right? Sometimes they're not aware, then we get them to be aware, then they are aware, and then they try to do something about it, and then perhaps they relapse and start all over again. That's part of the stages of change. Do not use beta blockers to treat cocaine overdose. Why? This will lead to a block in beta and unopposed alpha on the blood vessels. You're going to trigger a hypertensive crisis. Look for nasal septum rupture as a clue to cocaine overdose. Or hypertrophy if you're dealing with chronic use. Factitious disorder by another. This is also called Munchausen's by proxy. This would be a mother who is bringing her child to you in the ER and they have symptoms of severe hypoglycemia, and they look at their patient records and they seem to be coming in frequently with that, for example. And you check their blood sugar levels and you find insulin is extremely high and you find C-peptide is very low. So we know that we're dealing with an exogenous insulin. If you remember, in my endocrine lectures, I've explained this very well. So the mother is manifesting disease in her child by giving him insulin. We call this Munchausen's by proxy or factitious disorder by another person. PTSD, how do I know I'm dealing with PTSD in the clinical vignette? You want to look for flashbacks of the event, nightmares, sleep disturbances, avoidance of triggering stimuli. What is reaction formation? It is avoiding an unwanted feeling or thought with emphasis on the opposite. There are many, many examples of this. For example, number one, being mean and hating someone you actually have a crush on. We've all seen this. You might be at work and you find, some tensions that are happening between a male and female colleague. Perhaps there are some unresolved romantic feelings, and that is reaction formation. Another really good example of reaction formation is someone who wants to stress the opposite. There's so many examples of reaction formation in our daily life, but you'll get one where somebody is addicted to watching pornography and this person happens to be like a member of parliament or a lawmaker. So on the other hand, right, he's going to stress the opposite. He's going to push for laws that are banning pornography websites and making legislation against it. So you're going to get this extreme character, this opposite persona that's being manifested for someone who actually has a serious addiction to pornography. That was one excellent example of that. Longtime advocate of HS conversion therapy is secretly or a closeted homosexual themselves. So this is also a very classic example where you've had people in the past who would advocate for homosexual conversion therapy, and they themselves came out later and said that they themselves were homosexuals. That was a reaction formation. One of the examples that I really like about reaction formation, and I don't have the link for it, but there was this person who was a lawmaker as well, who was advocating for increasing the sentencing for strangulation crimes, any crime associated with strangulation or asphyxia of a partner, especially in the setting of a bedroom. He was really promoting for more and more crime, more and more punishment for it. And as soon as the bill was passed to law, his wife came out and his previous girlfriends came out that he was extremely abusive. And he would strangulate them often. He would try to do that. So that was a very sad example of reaction formation. And again, like I said, it's very common in our day-to-day life if you are aware of it. The mature defenses are conscious defenses and the immature are unconscious defenses. So what does that mean? So all those things that you see in the reaction formation, the splitting defense, all these things are unconscious. We're not aware that we are doing them ourselves. The conscious ones are things that we can do, and I'm going to explain to you the defenses in a way that just makes it very simple, right? Your mind doesn't really want to deal with inappropriate feelings or something that's causing a lot of distress or anxiety or depression, or whatever it is. Your mind has a defense mechanism to prevent, its ego from being affected or anything like that. So we have our immature defenses and we have mature defenses. And the really cool thing about mature defenses is You know, if you take some time to sit down and reflect on yourself, you might want to deploy the mature defenses to help yourself out through a difficult period of your life, or if you're dealing with something challenging. So the mature defenses are humor, altruism, sublimation, and suppression. Okay? So the one I like personally is humor. If you get yourself in a bad situation or something's going on and you just laugh it out. And we call it dark humor, but really it is a mature defense, and it can seriously help you get over a problem that you're dealing with. And of course, it might not be socially appropriate at certain times. I think there was an incident where, maybe if this is an example of it, where there was the whole Jake Paul situation with the suicide forest, and when he saw the person there, he started laughing, right? And a lot of people said it was inappropriate. And I do believe Dr. Phil also came out with this, and he said, like, you know, yes, it's an inappropriate response, and perhaps he did that, but that was a coping mechanism at that time. So humor, again, a bad thing happened to me, or say you failed an exam and you just laugh it off, and you and your friends laugh it off. So that's humor. Again, it might not always be socially appropriate, but sometimes we don't have the other options available to us at the moment. So I would prefer to just use what I have and not deal with a trauma at the moment. So the other thing is simply just to not deal with it, not to think about it right now. You know, I have exams coming up and something happened on the side. I'm actively suppressing it. I'm not going to think about it right now. I will think about it later, but I just don't want to think about it right now. That is suppression. Okay? Next is altruism. Now, altruism is basically you are going to do something really good to alleviate negative feelings, right? One of the classic examples is you're going to have a mafia boss. He feels guilty because his money is coming out of, you know, horrible things. So he's going to go and donate a massive amount of money to a cancer hospital or something like that. So that's altruism, right? He's going to relieve this negative feeling of, you know, how his money is coming into his life. And then he's going to do an immense act of altruism to relieve that tension, right? Next is sublimation. Now, sublimation is very interesting. It's trying to, you know, really look at yourself, and you're going to see something that, you know, you're dealing with, and you want to manifest it into something positive, right? So say somebody's aware that they have anger management issues, right? So what do they do, especially if it's like a young man, he's aware that he's angry all the time, and he knows, like, you know, being violent is dangerous, and if he assaults someone, he can, you know, go to jail. So he doesn't want to deal with that. So what's he going to do? He's going to do sublimation. He's going to go to the gym, and he's going to work out, right? He's going to go take dance lessons and, you know, just manifest that energy into his performance, right? That's sublimation. Another example of sublimation, I'm going to use one of the previous examples. If a man is addicted to pornography, right? He knows that this is inappropriate. So what is he going to do? He wants to manifest something positive out of this. So what is he going to do? He's going to, you know, use his art skills, and he's going to draw a lot of nude paintings, and now he's a successful artist, and he is opening up galleries everywhere. So he's using something that, you know, he thinks is inappropriate, he doesn't like it, but he's trying to channel it into something positive, and he's become a, you know, world-renowned artist, for example. That is an example of sublimation for you. Next, we're going to talk about child abuse. So we have to know what it looks like. This is extremely important on your board exams and in your life in general, because when a child comes to you, you are responsible for being totally aware of child abuse, because legally you will be responsible if something happens to this child and you did not pick it up. If you get fractures in places you typically do not get fractures, suspect child abuse. What are the fracture locations? In the femurs, in the legs, in a child who has not yet met the milestone for walking, right? You're going to get a baby, you know your milestones. He should be rolling around, not walking yet, but he comes to you with fractures in his legs. Well, then I shouldn't expect fractures in my legs, right? Baby's only rolling around. Okay? Fractures in the ribs here from grabbing the baby too tight. Fractures in the ribs. Shaken baby syndrome. Retinal hemorrhages. Those are all buzzwords for child abuse. You want to be aware of that and you want to report it if you suspect. Now there are things that are part of your differential for child abuse. Yani, مش كل fracture هتبقى child abuse, right? It can be an expected fracture, so I want to rule that out. It can be something called osteogenesis imperfecta, which is a bone disease where the person has very fragile bones and the most minimal of impact will lead to a fracture. However, osteogenesis imperfecta is less common, far less common than child abuse. You are better to bet that it's child abuse than to go to osteogenesis imperfecta. Plus there's other findings, genetic testing, blue sclera for OI. So what do? You report, right? You're supposed to report to Child Protective Services. Again, we've said the bruises on the backs, the broken hips, broken legs, and a baby that can't walk. Fractures at different healing stages, right? You did an x-ray of the baby, you're going to find, well, there's an old fracture here, an old fracture here, different healing stages. Inconsistent family history. You ask the patient, you ask the mother, and typically if it's child abuse, you want to think of the mother as the main person who's doing it. Sexual abuse is a bit older when the child has developed puberty age, and typically the aggressor is male. You want to look for inconsistent history from the family. You ask the mom, well, where did this bruise come from? Oh, she'll tell you something. And then you ask her, well, where did this fracture come from? Oh, it came from this. If she came to your office again and the baby came to your office again, you ask her about the bruises again or the fractures. You get a different story. So that's inconsistent history, right? An STD, a sexually transmitted disease. That is alarms and red flags in a child for sexual abuse. Retinal hemorrhages, like we've said, subdural hematoma from shaken baby syndrome. Now, what do you do if you get asked a question in medical law, if you reported it to CPS and it turned out after their investigation that it wasn't child abuse? Does the law protect you? Yes, the law will protect you because you have something called Good Samaritan law. So Good Samaritan means you acted in good faith, right? You were worried about this child and you did and you reported, it wasn't child abuse, okay. The law will protect you based on Good Samaritan law. If you don't report, you're going to be in a lot of trouble. So that is the end of this video on all of the most important points that you need to know for psychiatry. So I hope you guys learned something, and if you think someone else is going to benefit from this video, go ahead and share it with them, and I will definitely continue with this series, and I will see you guys in the next video. Take care.